If both parents are affected by the risk of the offspring developing the disease, it is estimated to be 1 in 3. The concordance rates of developing Crohn disease in monozygotic twins is 20 to 50%, and for the dizygotic twins it is 10%, which is suggestive of significant but not complete genetic predisposition. Even among the twins, there will be variations in the type of inflammatory bowel disease, a natural cause of the disease influenced by the environment, including smoking and several other factors. Several genes have been studied with respect to Crohn disease, but so far the strong and replicated associations have been identified in NOD2, IL-23R, and ATG16L1 genes. In Crohn disease, the NOD2 CARD15 gene has been associated with ileal involvement, fibrostenotic disease, earlier age of onset, and a family history of Crohn disease. Patients who carry heterogeneous NOD2 CARD15 genes have 2 to 4 times the increased risk of developing Crohn disease, whereas those with homogeneous alleles have 20 to 40-fold increased risk of developing Crohn disease. The IL-23R gene is involved in the differentiation of the T17 lymphocytes, resulting in dysregulated cytokine production, which is implicated in the pathogenesis of Crohn disease. The Th17 lymphocytes secretes interleukin-17, which is a key effector driving colitis in animal models. At this point of time, evaluating for genetic mutations in Crohn disease still remains a research tool, not yet proven to be of clinical benefit for diagnosis, treatment, or prognosis. Smoking is a very well-known modifiable risk factor for Crohn disease. It is associated with a twofold increase in the risk for Crohn disease, and this included early life exposure and passive smoking. Smoking is also associated with early onset of Crohn disease, more frequent need for immunosuppression, more surgical intervention, and higher rates of post-operative disease recurrence. Nicotine was long believed to be the trigger. However, trials based on nicotine replacement therapy and oral tobacco use did not yield similar results. Smoking has been shown to alter smooth muscle tone, influence endothelial function through nitric oxide production, affect gut mucosal integrity, cause oxidative stress, and influence gut microbiota. Observational studies have showed an inverse relationship between fiber intake and risk of Crohn disease. In the prospective nurses' health study, long-term dietary fiber intake was associated with lower risk of Crohn disease. The risk reduction was greatest for fiber derived from fruits, but no beneficial effect was observed with fiber from cereal, whole grains, or vegetables. The postulated mechanism for this protective effect is that the fiber is metabolized by the intestinal bacteria into short-chain fatty acids that inhibit transcription of pro-inflammatory mediators. Fiber also helps to maintain the integrity of the epithelial barrier and reduces the translocation of Escherichia coli across Peyer's patches in vitro. Animal studies have showed that the saturated fat diet was associated with increased inflammatory response mediated by type 1 T helper cells in interleukin 10 knockout mice. But prospective studies in human failed to reveal such an association. High consumption of N6 polysaturated fatty acids and low consumption of N3 polysaturated fatty acids has been associated with increased risk of Crohn disease. A case control study conducted in 1976 showed a higher incidence of inflammatory bowel disease in those who consumed larger amounts of refined carbohydrates. It has also been observed that newly diagnosed inflammatory bowel disease patients consumed less dietary fiber, less raw fruits and vegetables when compared with healthy individuals. The three most important lifestyle activities that have an effect on Crohn disease include sleep, stress, and exercise. Disturbed sleep is more common in Crohn disease and has been associated with active disease. This association is bidirectional, with active disease disrupting the sleep, and the poor sleep in turn might exacerbate inflammation. Large cohort studies have shown an association between major life stressors, anxiety, depression, and an increased risk of Crohn disease. In those with established disease, anxiety or depression are associated with relapse, hospitalization, surgery, reduced efficacy of immunomodulators, and impaired quality of life. Physical activity has been shown to be associated with lower risk of Crohn disease. A 1990 German study showed that those with sedentary occupations were at higher risk of developing inflammatory bowel disease when compared to those who were heavy manual laborers. This theory was supported by a prospective cohort study which showed a 44% reduction in the risk of Crohn disease in the cohort who performed rigorous physical activity. Similar to smoking, there is a paradoxical relationship between the appendectomy and the two inflammatory bowel disease. In large cohort study, patients who underwent appendectomy for acute appendicitis and mesenteric lymphadenitis had lower incidence of ulcerative colitis but had a higher incidence of Crohn disease. The association between appendectomy and Crohn disease has been long debated, since the inflammation in appendix and other associated symptoms could have been due to underlying Crohn disease than appendicitis, leading to diagnostic bias. For incident disease, the reason for appendectomy seems to be an important factor in determining the outcome. Appendectomy done for perforating appendix is associated with higher risk for developing Crohn disease, whereas appendectomy done for other causes is associated with a lower risk of Crohn disease. It has been shown that the inflammatory bowel disease patients have reduced diversity in gut microbiota when compared with the healthy individuals, and this change is more pronounced in Crohn disease than ulcerative colitis. Some of the external environmental factors which affect the gut microbiota include large family size, early exposure to pets and farm animals, breastfeeding, hygiene, stress, and diet. A 2004 study by Darfieux, Michaud, and others identified higher prevalence of adherent invasive Escherichia coli in Crohn disease patients. 22% versus 6% in control group. Adherent invasive Escherichia coli has the ability to invade intestinal epithelium and replicate in the macrophages. It has also been postulated that Faecalibacterium prausnitzii, a butyrate-producing bacteria from Firmicutes phylum, confer protection against inflammatory bowel disease. Dietary patterns affect the intestinal microbiota, and these changes in microbial composition could mediate the influence of diet or risk of incident disease. Enterotypes were strongly associated with long-term dietary patterns. Enterotype 1 correlates with Western diet rich in animal protein and saturated fat, whereas enterotype 2 correlates with a diet rich in the carbohydrate and fiber. Medications such as antibiotics, aspirin, non-steroidal anti-inflammatory drugs, and oral contraceptives have been implicated as potential risk factors for Crohn's disease. The use of antibiotics within the first year of life is associated with development of Crohn's disease. In a nested case control study by Shaw and others, 58% of the pediatric Crohn's disease patients received antibiotics within the first year of life when compared with 39% in the control group. The gut microbiota is unstable during early childhood, and the perturbation of this microbiota could influence the gut immune response and increase the susceptibility to inflammatory bowel disease. In contrast to the studies from Western world, a large population-based study from Asia showed protective association between antibiotic exposure and development of inflammatory bowel disease. There is a strong association between non-steroidal anti-inflammatory drugs and Crohn's disease, especially at higher doses and longer duration of use. Non-steroidal anti-inflammatory drugs might trigger relapse in up to 1/3 of the users. This effect is postulated to be mainly due to their non-selective inhibition of cyclooxygenase enzymes, as selective cyclooxygenase 2 inhibitors have shown to decrease the rate of relapse. In a prospective cohort study in United Kingdom, regular use of aspirin was associated with increased risk of Crohn's disease. Oral contraceptives have also shown to increase the risk of Crohn's disease by 1.5 times when compared with non-exposed women. Crohn's disease is typically characterized by transmural inflammation of the intestine and could affect any part of gastrointestinal tract from mouth to perianal area. In terms of distribution of the disease, 25% of the patients have colitis only, 25% is ileitis only, and 50% have ileocolitis. Approximately 1/3 of patients have perianal involvement, and 5 to 15% have involvement of oral or gastroduodenal area. Diarrhea is the most common symptom of active Crohn's disease due to decreased water absorption and increased secretion of electrolytes. Other causes of diarrhea in Crohn's disease include small bowel bacterial overgrowth, mainly in obstructive disease, and bile acid diarrhea due to diseased resected bowel. In ileocolitis, the symptoms mimic acute appendicitis with right lower quadrant abdominal pain, fever, and diarrhea. Extensive disease could result in malabsorption and stearia. Low-grade fever could be a manifestation of inflammatory process in Crohn disease, whereas high-grade fever often suggests intra-abdominal abscess or infectious process. About 10 to 20% weight loss is common in patients diagnosed with Crohn disease due to decreased oral intake and malabsorption. The common extra-intestinal manifestations in Crohn disease include large joint arthritis, uveitis, uritis, episcleritis, erythema nodosum, and pyoderma gangrenosum. The first international classification of inflammatory bowel disease was proposed at Rome in 1991 by the International Working Party based on anatomical distribution, operative history, and clinical behavior. This was replaced in 1998 by Vienna classification proposed by the World Congress of Gastroenterology, which considered age of onset, disease location, and disease behavior, that is shown in the table. In 2005, the current Montreal classification was proposed by the Working Party at the Montreal World Congress of Gastroenterology. The Montreal classification was essentially a revision of the Vienna classification, which kept the three predominant parameters but made modifications with each of these three categories. Montreal classification is widely used in both research and clinical practice. There is very limited data available on its reliability with excellent inter-observer agreement in Crohn disease. The major drawback of the current classification system was clearly identified to be instability of disease extent, behavior over a period of time, underlying the dynamic nature of inflammatory bowel disease. Prospective studies have showed that the patients with predominantly inflammatory disease at diagnosis are very likely to develop either fistulizing or stricturing complications within the next 20 years. Lehman Index is the newly available scoring system to quantify the global digestive tract damage mediated by Crohn disease over a period of time. It is considered equivalent to the Sharp Index used to quantity joint space narrowing in rheumatoid arthritis. Change in Lehman Index may be used to stratify the patients into aggressive, indolent, or treatment-responsive types. The diagnostic workup of Crohn disease is usually undertaken based on the presenting symptoms, physical findings, and basic laboratory abnormalities. The key features for diagnosing Crohn disease comprises of combination of radiographic, endoscopic, and pathological findings demonstrating focal, asymmetric, transmural, or granulomatous features. It is important to consider other diseases which can mimic Crohn disease. Additional serologic studies that are evolving as adjunctive tests to aid in the diagnosis of Crohn disease include antibodies against Saccharomyces cerevisiae, anti-neutrophilic cytoplasmic antibodies, antibodies directed against CBIR1 and OMPC. Initial blood studies include complete blood count, basic metabolic panel, erythrocyte sedimentation rate, C-reactive protein, liver function tests, iron studies, vitamin B12 levels, and vitamin D levels. The blood counts often reveal the presence of anemia in patients with Crohn disease. The most common etiologies for anemia in Crohn disease include iron deficiency, anemia of chronic disease, and vitamin B12 deficiency. The presence of fecal neutrophil-derived biomarkers is an excellent way to detect intestinal inflammation. They correlate closely with endoscopic activity in Crohn's disease and allows serial monitoring of disease activity and of treatment success, and can even serve in predicting clinical relapse or sustained remission. If diarrhea is present, stool should be tested for enteric pathogens of parasites and Clostridium difficile toxin. Upper lower gastrointestinal endoscopy is routinely used to confirm the diagnosis of Crohn's disease, assess disease location, and obtain tissue for pathological evaluation. The endoscopic appearance of Crohn's disease is highly variable and changes with disease activity and duration. In early mild Crohn's disease, the mucosa appears endoscopically normal or small, punched out. Aphthous ulcers are often seen, like on the left picture in duodenal Crohn's disease. These aphthous ulcers are a result of submucosal lymphoid follicle expansion. In moderate disease, the aphthous ulcers coalesce into larger ulcers, as on the right picture, which may take on the appearance of a star. As disease severity increases, submucosal edema and injury can result in cobblestoning of the mucosa, which is seen more often in Crohn's disease colitis than in ulcerative colitis. Patients with severe disease may have large, linear, and deep serpiginous ulcers. On the picture you see Crohn's disease colitis in descending colon. Crohn's disease colitis may be endoscopically indistinguishable from ulcerative colitis and may still have skip areas that are endoscopically and histologically completely normal. Crohn's disease colitis usually spares the rectum and is most severe in the cecum and right colon. Diagnosis of Crohn's disease may be accomplished either by contrast radiography, computed tomography, or magnetic resonance imaging scans, and also to confirm disease location and intestinal complications. Plain radiographs still play a role as a first-line imaging tool for Crohn's disease in the detection of bowel dilation, obstruction, bowel perforation, and bowel wall thickening. On the picture, you see a plain radiograph of a 31-year-old woman with small bowel obstruction. There are multiple distended loops of bowel with plica circularis, shown by the arrows, consistent with small bowel obstruction. There is a collapse of the colon. Cholecystectomy clips are incidentally noted, shown by the arrowhead. The main advantage of plain radiographs include its portability, availability, inexpensive, and low radiation exposure. Small bowel enteroclysis have been used historically to assess patients with suspected or established Crohn's disease. On the picture you see the CT enteroclysis findings from a patient with Crohn's disease that shows small bowel wall thickness, wall enhancement, and presence of an increase in the concentration of fat tissue surrounding the intestine. This is shown by the arrow. CT scan image clearly shows bowel wall thickening at the distal ileum, shown by the arrowhead, and colon, shown by the arrows. The thickened wall has a stratified appearance, increased mesenteric vascularity. Comp sign is noted around the involved segment. These findings are suggestive of active lesion from Crohn disease. MR image shows a Crohn lesion with prominent wall thickening at the distal ileum, shown by the arrows. Crohn disease, also known as regional enteritis, may occur in any area of the gastrointestinal tract, but the most common sites involved at the presentation are the terminal ileum, ileocecal valve, and cecum. Disease is limited to the small intestine, shown on the left picture, alone in about 40% of cases. The small intestine and the colon both are involved in 30% of patients, and the remainder of cases are characterized by colonic involvement only. Infrequently, Crohn disease may involve the esophagus or stomach. The presence of multiple separate, sharply delineated areas of disease resulting in skip lesions is characteristic of Crohn disease and may help in differentiation from ulcerative colitis. Strictures are common, as shown on the picture on the left. The earliest lesion, the aphthous ulcer, may progress, and multiple lesions often coalesce into elongated serpentine ulcers oriented along the axis of the bowel. Edema and loss of normal mucosal folds are common. Sparing of interspersed mucosa results in coarsely textured cobblestone appearance, as on the picture on the right, in which diseased tissue is depressed below the level of normal mucosa. Fissures frequently develop between mucosal folds and may extend deeply to become sites of perforation or fistula tracts. The intestinal wall is thickened as a consequence of transmural edema, inflammation, submucosal fibrosis, and hypertrophy of the muscularis propria, all of which contribute to stricture formation. In cases with extensive transmural disease, mesenteric fat frequently extends around the serosal surface and is known as creeping fat, as shown on the picture with the arrow on the right. The microscopic features of active Crohn disease include abundant neutrophils that infiltrate and damage creep epithelium, and they are known as cryptitis, as shown on the left picture with the black arrow. Clusters of neutrophils within a crypt are referred to as a crypt abscess, shown by the yellow arrow, and are often associated with crypt destruction. Ulceration is common in Crohn disease, and there may be an abrupt transition between ulcerated and normal mucosa. Repeated cycles of crypt destruction and regeneration lead to distortion of mucosal architecture. The normally straight and parallel crypts take on bizarre branching shapes and unusual orientation to one another. Epithelial metaplasia, another consequence of chronic relapsing injury, often takes the form of gastric antrolaparine glands. On the left picture you see pylori gland metaplasia. Compound acinar glands lined by antral-type mucosa of stomach are observed in the lamina propria, shown by the arrow. Paneth cell metaplasia may occur in the left colon, where Paneth cells are normally absent. On the right picture, you see Paneth cell hyperplasia. These cells with numerous cytoplasmic granules are situated at the base of crypts of Lieberkühn glands. These architectural and metaplastic changes may persist even when active inflammation has resolved. Mucosal atrophy with loss of crypts may follow years of disease. Non-Cassating granulomas, a hallmark of Crohn disease, are found in approximately 35% of cases and may arise in areas of active disease or uninvolved regions in any layer of the intestinal wall. They are shown by the stars on both pictures. Granulomas also may be found in mesenteric lymph nodes. Cutaneous granulomas form nodules that are referred to misleadingly as metastatic Crohn disease. The absence of granulomas does not preclude a diagnosis of Crohn disease. Non-cassating epithelioid granulomas can be found in any layer of the intestinal wall. Here you see granulomas within mucolaris propria in a colectomy specimen. We'll have a look at the case report of a patient with Crohn disease. A 43-year-old male presented at the hospital with worsening symptoms of low back pain and was compulsively posed in a lateral position. No abdominal or digestive syndromes were observed. The dietary intake of the patients had not changed. However, the patient had lost 15 kilograms of body weight in 12 months. X-ray examination showed thoracolumbar spine degeneration, shown on the left. A computed tomography scan was subsequently performed, revealing thoracolumbar spine degeneration and mesenteric lymph node tumescence, shown on the middle, as did single photon emission computed tomography, shown on the right. The patient had no history of long-term use of corticosteroids and no bone fractures, and had a 10-year history of cigarette smoking at a rate of 6 cigarettes per day. The body weight of the patient was 71 kilograms and body mass index was 23.92. Physical examination revealed pressing pain in the cervical, lumbar and thoracic vertebrae and obvious clubbing of the fingers and feet, shown on the picture. Other inspections of the lung, heart and abdomen proved unremarkable. You can see the results of the laboratory data with hemoglobin level of 103, serum albumin level of 23.9, erythrocyte sedimentation rate of 50, C-reactive protein level of 63.5, reduced serum 25-hydroxy vitamin D level of 37. No positive results were identified for serum, paraffin, gonadin, calcium, phosphate, magnesium, alkaline phosphatase, and human leukocyte antigen B27. Colonoscopy demonstrated an inflamed and strictured ileocecal valve with less inflammation in the ascending transverse colon, sigmoid colon, and rectum, compatible with Crohn's disease. However, the coloscope could not pass through the restricted ileocecal valve, shown on the left and right pictures. An ileocecal valve biopsy indicated chronic active colitis with ulcers and inflammatory granulation tissue, suggestive of Crohn disease, shown on the pictures. The biopsy tissue was stained with hematoxylin and eosine, and you can see the result. An abdominal computed tomography scan indicated marked symmetric segmental thickening at the jejunum wall, shown by the white arrows. Duodenal balloon enteroscopy demonstrated segmental ulceration and stricture in the jejunum, shown by the arrow. A jejunum biopsy revealed chronic active colitis with necrosis, shown by the yellow arrow, and ulceration, shown by the red arrow. The patient was diagnosed with Crohn disease as a result of the following examination. It was suspected that osteoporosis may be an extra-intestinal manifestation of Crohn's disease. Steroids and biological agents were prescribed in sequence. Inflammatory markers returned to normal after 1.5 years of treatment. According to this case, osteoporosis with unknown causes should be considered as a possible sign of small intestinal Crohn disease. Reduced bone density is an extra-intestinal manifestation and a common complication of inflammatory bowel disease. However, osteoporosis as an initial symptom of inflammatory bowel disease is rare. The present report detailed the case of osteoporosis as a presenting manifestation of Crohn disease, and osteoporosis was improved following treatment of Crohn disease with glucocorticoids. The possible reasons leading to osteoporosis in inflammatory bowel disease are corticosteroid use, smoking, and gut inflammation. No history of corticosteroid use and metabolic bone disease were tracked in the present patient. Smoking alone did not suitably explain osteoporosis. Therefore, the inflammatory activity of Crohn disease itself may be a main contributor to osteoporosis. One of the possible mechanisms of osteoporosis in inflammatory bowel disease is malabsorption. Calcium deficiency and low vitamin D levels occurred as a result of small intestinal dysfunction in the present patient. A previous 5-year study identified that low vitamin D levels are common in patients with inflammatory bowel disease, and inflammatory bowel disease patients with low mean vitamin D levels demonstrated worse disease activity, worse pain, and high requirement for steroids. The use of vitamin D may improve osteoporosis. However, this was not the case for the present patient. Low back pain was not improved following treatment with calcium and vitamin D. Furthermore, although low back pain improved following steroid and biological treatment, endoscopic performance was not notably improved in the present case. This phenomenon suggested that malabsorption may be a partial cause of osteoporosis in Crohn's disease, and osteoporosis may be the result of extra-intestinal inflammation. Another disease that belongs to the group of granulomatosis is a vaginal granulomatosis. Regenerous granulomatosis is an idiopathic, systemic, inflammatory disease characterized by necrotizing granulomatous inflammation and pauci-immune small vessel vasculitis of upper and lower respiratory tract and kidneys, although other organs or tissues can be affected. The clinical manifestation of vaginal granulomatosis are usually limited to the upper and lower respiratory tract, although a number of other clinical features can arise. The lungs are commonly involved, and this may range from asymptomatic nodules to pulmonary infiltrates and fulminant alveolar hemorrhage. Renal involvement most commonly consists of segmental necrotizing glomerulonephritis, though proliferative glomerulonephritis may also be observed. The range of other organ systems that may be involved by vaginal granulomatosis is vast. Musculoskeletal system involvement may manifest as myalgias, arthralgias, and arthritis. Although cutaneous lesions include palpable purpura, ulcers, vesicles, papules, and subcutaneous nodules. Although rare, cardiac involvement may include pericarditis and valvular lesions. Neurological symptoms may present in the form of mononeuritis complex, neuropathy, stroke, seizure, cerebritis or meningitis. Generalized symptom such as fever and malaise may also be present. Regenerous granulomatosis was first reported by Friedrich Wegener in 1936, incorporating both clinical and histopathological criteria to describe what he believed represented a unique and distinctive syndrome. The classic histopathological criteria involve three major features: necrotizing granulomatous lesions in the upper and lower respiratory tract, generalized necrotizing vasculitis involving both arteries and veins, and glomerulitis. Since the time, the clinical and histopathological manifestations of vaginal granulomatosis have been well defined. However, the precise etiology of vaginal granulomatosis remains unknown. We will discuss further etiological aspects of vaginal granulomatosis, its pathogenesis, morphological and clinical manifestations. This condition is rare. The worldwide prevalence of vaginal granulomatosis is estimated to be 23.7 to 156.5 per million, with an estimated annual incidence of 3 to 14 per million. Since the publication of the 1990 American College of Rheumatology classification criteria and also the 1992 Chapel Hill Consensus Conference on nomenclature of vasculitis, a number of epidemiological studies have been undertaken to estimate the incidence of vaginal granulomatosis. The reported data demonstrate geographical variation in the frequency of vaginal granulomatosis, possibly reflecting different diagnostic methodologies. Furthermore, many of the studies have been retrospective and hospital-based, therefore underestimating the true incidence of the disease. The majority of epidemiological data on vaginal granulomatosis come from Europe, where the annual incidence rate of vaginal granulomatosis is 3 to 14 per million. The highest prevalence rate of vaginal granulomatosis in Europe were estimated to be 63 per million and 95 per million in the United Kingdom and Norway, respectively. Vaginal granulomatosis affects both genders equally, although some inconsistent gender differences have been observed. Vaginal granulomatosis typically affects adults, although a small number of young and children may be affected. The mean age of patient at diagnosis is between 40 and 55 years. The etiology of vaginal granulomatosis remains unknown. A number of exogenous factors have been suggested to be of etiological relevance. Etiological aspects of clinical and experimental data suggest that microbial exogenous factors may possibly give rise to the disease expression. As such, vaginal granulomatosis might be triggered by a pathogenous reactions to a foreign agent, in which specific autoimmune responses may cause aggravation, spread, and chronicity of the inflammatory response. The infectious agent probably causes non-specific activation of the immune system, resulting in elevation of cytokine levels in the presence of ANCA and leading to cell destruction. Exposure to infectious agents such as Staphylococcus aureus, Mycobacterium avium intracellulare, or parvovirus B19, and fungi have been associated with Regenerous granulomatosis. Staphylococcus aureus is known to have the ability to act as a B-cell mitogen and possibly induce the production of ANCA by autoreactive B cells. Furthermore, bacterial toxins may function as superantigens that enhance B and T cell stimulation, resulting in production of ANCA. Reports have suggested that parvovirus B19 infection is associated with the development of Regenerous granulomatosis, or relapse of the disease have not been consistent. Infection by cytomegalovirus has been reported to mimic Regenerous granulomatosis, but is not associated with Regenerous granulomatosis, although it has been suggested that cytomegalovirus reactivation may contribute to relapse of Regenerous granulomatosis due to changes in the CD8 plus T cell compartment. Environmental factors have been proposed as potential trigger factors of Regenerous granulomatosis. ANCA-associated glomerulonephritis and vasculitis can be associated with exposure to silicon-containing compounds, and also it has been suggested that occupational exposure to crystalline silica or other occupational exposures such as hydrocarbons in paints and glues, inhaled fumes, and particulates. However, the evidence is conflicting. There is no consistent pattern of human leukocyte antigen HLA genotype association with Regenerous granulomatosis that has been observed. Some studies have revealed no human leukocyte antigen association, while associations with human leukocyte antigen B8, human leukocyte antigen A9, A10, and BW22, B52 DR9, or the DR4 D27 halotype, and DR13 DR6 DQW7 have been observed. Other genetic markers such as polymorphism of genes, of cytokines, chemokines, adhesion of molecules, or proteinase 3 may be associated with the presence of ANCA that might give a common cytoplasmic pattern by immunofluorescence and directed against proteinase 3. T-cell function associated genetic factors may predispose to granulomatosis inflammation and PR3 ANCA seropositivity, and therefore be genetic risk factors for Regenerous granulomatosis. Clinical manifestations can affect a wide spectrum of systems, although often the disease is limited to a small number of organs. A typical presentation is involvement of the upper respiratory tract, lungs, and kidneys. Less common sites of involvement include skin, central nervous system, heart, salivary gland, eye and orbit, breasts, gastrointestinal tract, spleen, pituitary gland, thyroid gland, and urogenital tract. Regenerous granulomatosis has a wide range of initial presenting symptoms, including fever, malaise, pyrexia, headache, night sweats, anorexia, persistent rhinorrhea or epiphora, purulent bloody nasal discharge, oral endonasal ulcers, chronic sinusitis, sore throat, earache, hearing loss, hoarseness, stridor, dysphonia, cough, dyspnea, visual loss, salivary gland enlargement, arthritis, arthralgia, myalgias, peripheral neuropathy, weight loss, and abdominal pain. The term limited was first used by Carrington and Leibov to describe Regenerous granulomatosis involvement of the lung in the absence of renal disease. However, the European Vasculitis Study Group recommends grading disease severity of the anti-neutrophil cytoplasmic antibodies ANCA associated vasculitis into the following 5 categories: localized, with upper and or lower respiratory tract disease without any other systemic involvement or constitutional symptoms; early systemic, any without organ-threatening or life-threatening disease. The former term generalized can also be subdivided into generalized, renal or other organ-threatening disease, serum creatinine level less than 5.6, severe with renal or other vital organ failure, serum creatinine level exceeding 5.6, and refractory, a progressive disease unresponsive to glucocorticoids and cyclophosphamide. Upper respiratory tract disease occurs in 95% of patients with Regenerous granulomatosis. Upper respiratory disease is often the initial presentation, although may be unrecognized by clinicians for several months until other manifestations of vaginal granulomatosis arise. Patients may complain of nasal obstruction, crusting, foul-smelling rhinorrhea, purulent nasal discharge, epistaxis, hypersomnia due to mucosal swelling, and epiphora caused by involvement of both the nasolacrimal duct and the lacrimal sac. Sinusitis can occur in up to 73% of patients as a solitary feature, although chronic sinusitis occurs in approximately 50% of patients with nasal involvement of vaginal granulomatosis. Vaginal granulomatosis commonly involves the pulmonary parenchyma and bronchi, and rarely the pleura. Necrotizing granulomatous pulmonary inflammation gives rise to a variety of non-specific symptoms such as cough, which is usually unproductive, pyrexia, hemoptysis, dyspnea, thoracic pain, pulmonary collapse, and post-obstructive infection. The most common feature of lung disease is the radiological presence of single or multiple cavitary nodules of 5 to 100 mm diameter at cortical and subpleural sites. If not treated, most of these nodules become excavated. Nodular disease is present in more than 70% of patients with lung disease and usually subpleural, while cavitary disease is observed in 35 to 50% of patients with lung involvement. Segmental or lobal atelectasis and hilar and mediastinal lymphadenopathy can also arise. Pleural disease is reported in up to 50% of affected individuals. It consists mainly of pleural effusion and thickening, although pneumothorax and bronchopleural fistula may rarely occur. On the pictures, you see chest radiograph on the left and computed tomography image on the right showing multiple nodular lesions in both lands, shown by the arrows. Renal involvement is common and usually preceded by extrarenal manifestations. In vaginal granulomatosis, about 20% of patients may have renal disease at the time of diagnosis, and about 80% of patients eventually develop glomerulonephritis with decreased glomerular filtration rate and hematuria. The renal disease is usually initially asymptomatic, although with time can be potentially fatal. Rapidly progressive glomerulonephritis occurs in 5% of patients with Regenerous granulomatosis, manifesting clinically as edema and hypertension. Glomerulonephritis of vaginal granulomatosis is focal, segmental, crescentic, and necrotizing. On the left picture, you can see massive necrosis that is usually associated to diffuse circumferential extracapillary proliferation. From a clinical point of view, the patient is affected by rapidly progressive renal failure. The glomerulonephritis can lead to rupture of Bowman's capsule, as shown on the right picture, with extensive ruptures. Regenerous granulomatosis has three distinctive histopathological features: necrosis, granulomatous inflammation, and vasculitis. The necrotic areas are basophilic with granular appearance and characterized by being in a patchy distribution throughout the affected tissue with serpiginous borders and surrounded by multinucleated giant cells. On the left picture, you see glomerulus with necrosis affecting more than 50% of capillary tuft with voluminous cellular crescent, shown by the arrow. Surrounding tubules with flattened epithelium and signs of ischemia, meaning acute tubular necrosis. On the right picture, you see a patient with vaginal granulomatosis demonstrating segmental fibrinoid necrosis and early cellular crescent formation, shown by the yellow arrow. The granulomatosis inflammation is characterized by a collection of loose macrophages, shown by the white arrows on the left picture, and multinucleated giant cells, shown by the yellow arrows on the picture on the right, and acute or chronic inflammatory cells, while the vasculitis in vaginal granulomatosis is a true vasculitis and often has little microscopic findings of vascular damage of the affected tissues. The vasculitis of Regenerous granulomatosis typically shows fibrinoid necrosis, shown by the white arrow, affecting the walls of small to medium-sized arteries and veins. The affected vessel wall has acute or chronic inflammatory infiltrate and occasionally accompanied by granulomatous infection within the vessel wall. The cellular composition of the granulomatous lesions of Regenerous granulomatosis are composed of CD4 plus T cells, CD8 plus T cells, histiocytes, CD20 plus B lymphocytes, neutrophil granulocytes, CD68 plus macrophages, and CD68 plus multinucleated giant cells that envelope a central area of necrosis. The central necrosis can be distinct and well-defined or as ill-defined serpiginous pattern of necrosis. The central area of necrosis is acellular or may occasionally contain polymorphonuclear leukocytes and epithelioid histiocytes, which may get arranged around the necrotic foci. The necrotizing vasculitis of Regenerous granulomatosis mainly affect the small and medium-sized vessels in vaginal granulomatosis, for example, capillaries, venules, arteries, shown on the left and right pictures. Endothelial cells are the target of the initial injury in vasculitis of Regenerous granulomatosis, which leads to swelling, necrosis, and detachment of endothelial cells. The vasculitis of Regenerous granulomatosis have also polymorphic pattern ranging from cutaneous leukocytoclastic vasculitis to necrotizing granulomatosis arteritis involving the small and medium-sized vessels. Immunoglobulin and/or complement deposits are fairly or not detected in glomerular lesions or at other sites, hence why the term pauci-immune is applied. The diagnostic criteria of Regenerous granulomatosis require that at least two frequent features must be present as summarized here. Nasal or oral inflammation with development of painful or painless oral ulcers or purulent or bloody nasal discharge. An abnormal chest radiograph showing the presence of nodules, fixed infiltrates or cavities. Urinary sediment with microhematuria or red cell cast in urine. Granulomatous inflammation on biopsy with histological change showing granulomatous inflammation within the wall of an artery or in the perivascular or extravascular area. The absence of granulomatous inflammation on biopsy requires a positive anchor test to fulfill the diagnosis of Regenerous granulomatosis. Early diagnosis can be difficult as a number of non-specific manifestations of Regenerous granulomatosis, such as persistent rhinorrhea, dyspnea, oral ulcers, chronic sinusitis, and arthralgia, arise with many other diseases. However, suspicion of Regenerous granulomatosis should be raised when these manifestations do not quickly subside. Although the clinical history and examination may point towards the diagnosis of Regenerous granulomatosis, there is always a need to undertake additional investigation to confirm the diagnosis of Regenerous granulomatosis and of course exclude other diseases likely to give rise to similar clinical picture. Identical likely disease include connective tissue disease, malignancy, sarcoidosis, interstitial lung disease, infections, drug toxicity, and others. Infections like subacute bacterial endocarditis, syphilis, tuberculosis, histoplasmosis, HIV. Neoplasms including malignancy and Hodgkin's lymphoma, connective tissue disease including systemic lupus erythematosus, rheumatoid arthritis. Other granulomatous diseases including sarcoidosis, granuloma gangrenescens, other causes of glomerulonephritis, antiglomerular basement membrane disease, post-streptococcal nephritis, allergic granuloma and Löffer syndrome, other hemorrhagic disease like alveolar hemorrhage syndrome, and use of drugs like cocaine abuse, medications such as minocycline and hydralazine. Laboratory testing should include all possible investigations that can rule out any disease that might be mistaken for Regenerous granulomatosis. Therefore, it is required to have a full blood cell count and differential white cell hepatic and renal biochemistry, urinalysis, cryoglobulins, and serology for HIV, hepatitis B and C viruses. Immunological investigations are carried out to differentiate Regenerous granulomatosis from other likely diseases, but may be not essential if ANCA are detected. Regenerous granulomatosis always warrants therapy, as although disease may progress variably there is a risk of significant tissue destruction. Before immunosuppressive therapies were introduced, the prognosis of Regenerous granulomatosis was poor, the mean survival time being 5 months with a 1-year mortality rate of 82%. The choice of therapeutic agents for Regenerous granulomatosis depends on the severity of the disease, or whether the disease is limited or generalized. Disease that gives rise to rapidly progressive glomerulonephritis, diffuse alveolar hemorrhage, and mononeuritis multiplex requires potent therapies, while mild limited disease may not warrant such an approach. It has been suggested that therapy should be flexible and based on the disease activity, type of morphological changes, and indications and contraindications of the selected drug. There remains no method other than clinical evaluation by which disease activity can be truly monitored. Immunosuppressive regimes have improved the prognosis such that the 5-year survival is now of the order of 70 to 80% patients. Nevertheless, in only 75% of patients, the remission could be achieved. Relapses can arise in approximately 50% of patients, and recurrence occurring within 18 months to 15 years following remission. Recurrence is seen in limited as well as generalized disease, and mainly related to the granulomata formation. Risk factors for relapses include discontinuation of therapy, rapid tapering of corticosteroids, previous relapse in disease, and persistent positive ANCA during the remission period. Regenerous granulomatosis is a multi-system disorder that can be associated with substantial morbidity and mortality. The etiology of Regenerous granulomatosis remains unknown, but varieties of potential causative factors lead to immunologically driven inflammation and necrosis, particularly of the upper and lower airways and kidneys. Although there is likely evidence to suggest that ANCA play a pathogenic role in Regenerous granulomatosis, their discovery has made the diagnosis of this disease even more possible, but there is almost always a need to confirm the diagnosis via histologic examination of the lesional tissue. If untreated, Regenerous granulomatosis will almost always cause death within 1 year of diagnosis, and although remission is possible, relapse can occur and there is lasting organ damage. Regenerous granulomatosis remain a clinical challenge for the 21st century that perhaps will be overcome by the increasing availability of immunologically specific therapeutic agents and the introductional criteria of particular methods to determine its etiology. We are going to stop today with Regenerous granulomatosis, and we'll continue and actually finish our topic of chronic inflammation during the next class. Thank you for your attention.